So now we are discussing about the lung patterns. So before going to that, we should know the anatomy of the respiratory tract in the dogs. So it starts with the trachea, and the trachea bifurcates into the bronchi, and that subsequently divides into the primary, secondary, and tertiary. And at the end, it will be end up in the terminal bronchiole, which will open into the alveoli. So these alveolar sacs where the gas exchange takes place, and the space between these bronchioles is called interstitium. So these three anatomical structures, if something happens this place, they will show certain X-ray radiographic signs in the X-ray. So based on that, we can diagnose certain diseases. Okay. So coming to the first pattern, that is alveolar pattern. So we can see here the alveoli, which should usually filled with the air, but because of some external reasons like the formation of the pus, or if the animal undergone for any accident, that will leads to the hemorrhage into the air sacs. So the blood will be fluid, sometimes pus, or in very few occasions the edema fluid will be accumulated in the alveoli. So if that happens, so if the alveoli is filled with the fluid other than the air, then the air will be coming to the terminal bronchiole but will not participate in the gas exchange. So the air will be left in these bronchioles. So these bronchioles filled with air will appear as the typical radiographic appearance, that is called as air bronchogram. So this is a very peculiar thing we can see with the alveolar pattern. So coming to the other most important radiographic sign with the alveolar pattern, that is lobar sign. So if you see here, this is the lung lobe, and for example, we will see this structure here, and if the alveoli is filled with the fluid, and if the bronchioles are normal, then we can see the air bronchograms. So there is a one particular situation where these bronchioles will also be filled with the fluid. So at that time, then we can see radiographically, we will see only the complete haziness, which is involving entire lobe. So that is called as lobar sign, where the radiographically we will see this lobe as hazy appearance. But thing you should remember here is, in order to see this lobar sign, the affected lung lobe should be parallel to the normal lung lobe. Okay. So for example, this is the normal lung lobe and this is the affected lung lobe, this is the this is the junction. So if X-rays are coming like this, then obviously there is a high chance that it will the normal lung lobe will be superimposing on the abnormal lung lobe. So there will not be there is a chance that the affected lung lobe may not be visible as the lobar sign. Okay. So but when the lung lobe is the affected lung lobe is towards the other side of the lung lobe, normal healthy lung lobe, and the X-ray comes like this, then obviously you can see the lobar sign very clearly. So the requirement here is the X-ray should be parallel to the junction between the healthy and unhealthy lung lobe. So this is about the alveolar pattern. So here you should differentially diagnose it with the atelectasis. The atelectasis is the failure of alveoli to contain the air with many reasons. So if any obstruction is there, then obviously the ventilation will be poor, then the lung lobe may be collapsed. So how to differentiate this atelectasis from the alveolar pattern? So there is an interesting correlation between both of them. Most of the times the atelectasis will show the mediastinal shift. Consider this as a ventrodorsal radiograph, this is heart and this is the lung lobe. So entire mediastinum, this is the mediastinal space. If some lung lobe here is collapsed, then obviously the space occupied by this lung lobe will be reduced, and subsequently the mediastinum will shift towards that side, the affected towards the affected lung lobe side. So the mediastinal shift will be towards the affected lung lobe. So the interesting thing here is the most of the times the atelectic lung lobe will be showing the alveolar pattern. To differentiate this atelectic lung lobe whether it is having the alveolar pattern or not, that cannot be achieved through the radiographs alone. You may need to have the CT scan for that purpose. So now see this lung collapse. Whenever the lung is collapsed because of the external compression or some bronchial obstruction, we will see the collapse of the lung lobes. So you cannot have the proper visualization of the lung as you normally see them. So coming to the next pattern, that is bronchial pattern. So this bronchial pattern, it is mostly seen with the allergic airway disease. This is the most common cause for the bronchial pattern, and the other least common causes are includes the infections and chronic irritation. We should know how different type of projections of the bronchi will give different type of appearance. So consider this as a bronchi. So if the bronchi is like this and X-ray is coming from the above, so this will give only the outline of the structure, irrespective of how much length of the bronchi is, how much thickness it might be having, but the end product will be only this. Since the X-rays can only give the two-dimensional structure of a three-dimensional organ, so we will be having only this structure. So that's why this projection is called end-on projection. So there is one more projection called side-on. Side-on means the X-ray is coming from above and the bronchi is like this. Then we will get this structure, the outline of the side-on projection. So technically we call this as donut and this as tram lines. Side-on projection will give the tram lines and the end-on projection will gives to the donuts. So radiographically, if we see the donuts and tram lines, then we can consider the animal might be having the bronchial pattern. So different types of bronchial diseases, if they persist without treatment, it will lead to the formation of the collapse of the lung that can be seen most commonly with cats which are having the chronic asthma. So the most common lung lobe collapse in cats is right middle lung lobe. So this is the most common lung lobe is affected with the asthma in cats. So one more consequence of this bronchial disease is bronchiectasis. This is permanent dilatation of the bronchi, and most of the times it is related to the tracheal collapse. So this can be because of the correlation between the cartilaginous malformation in the body. So in some cases, if the cat is having dyspnea for the longer time, otherwise if it is coughing for the persistently for the longer time, then there is a high chance that it may end up with the spontaneous rib fractures. So this is not only because of the dyspnea or cough, but the other reasons like the osteopenic conditions and age can be contributory factors for this. So one more important thing you can see with the chronic bronchial disease is the hyperinflation of the lungs. So clinically you can diagnose a cat with asthma with the hyperinflation of the lungs. So you can see the flat diaphragm with the hyperinflation of the lungs, because if this is the normal this is the diaphragm, usually it will be like this, the dome shaped, but because of the hyperinflation of the lungs, the pressure will be applied onto the diaphragm. So that will end up in flat diaphragm with the hyperinflation of the entire lungs. So there is one more thing you should remember, the fact that this is the heart. So for example, heart is like this, and a certain distance will be there between the diaphragm and the heart. So since the diaphragm is becoming flat, so this is positively correlated with the increasing in the distance between the heart and the diaphragm. So the flattening of the diaphragm will result in increasing the distance between heart and diaphragm. So one more important thing you should remember is the tenting of the diaphragm. This can be seen with the ventrodorsal X-ray. So since the diaphragm is having attachments with the coastal cartilages, so the coastal attachment of the diaphragm will be stretched because of the pressure. So that will be manifested in the form of tents. So like this. So because of that increased tension at the attachment of the diaphragm, so that will be seen as the tents. So the tenting of the diaphragm can be seen with this hyperinflation of the lungs and also during the tension pneumothorax. So these are the two conditions where you can see the tenting of the diaphragm, and you must remember this radiographic sign. So now coming to the last pattern, the interstitial pattern. Means I am discussing the most important patterns. There is one more pattern called vascular pattern, but I am not going to discuss here. So I already said at the beginning, the interstitial space is between the bronchioles. So even though the bronchial pattern, if we discuss something happens to the bronchial wall, so that can be manifested as a bronchial pattern. So interestingly, if the peribronchial space like here, if something happens to here, then it will appear as the bronchial pattern also. So technically the anatomical position is the interstitium, affected region is the interstitium, but the pattern we will see here is the bronchial pattern. So it is not always the pathological radiographic signs may not be related to the actual anatomical disturbance in the lungs. So now see the interstitial pattern. So the structural interstitial pattern includes the nodules and the masses. So we know the nodule can be round and the mass is also almost round but vary in the size, where the nodule is mostly is less than 2 centimeters and the mass is mostly the more than 2 centimeters. So this size is important in order to categorize the small structures, whether they comes under the nodule or mass. So even the nodule is less than 2 centimeter, there is a threshold level for the nodule to be appeared on the radiograph. So they should be having at least 7 to 9 mm in size, then only it will be visible radiographically. So that is not true with the mass, because the masses which are having the diameter of more than 2 centimeters, they can appear very easily in the radiographs. But the only exception is if any alveolar pattern is coexist with the mass, then it is very difficult to diagnose through the radiograph. There are few chances where you are going to misdiagnose the normal structures like the pulmonary vessels as the nodules. That happens because if the vessels are projected by the end on projection. See, for example, X-rays are coming like this and the vessel is like here, and the end on projection means the vessel, this particular portion is parallel to the X-rays. So the irrespective of the depth of this much, whatever the depth is, it will appear as a teeny small nodule like structure here. So that is like the X-ray is just giving the shadow of the structure on the film. So this portion, since it is having the side on projection, it will appear normally as their outline. The only way to differentiate the small structure, whether it is a pulmonary vessel or nodule, is by observing the continuation of the small mass towards the lateral side, that is called as the tail. So since it is a blood vessel, it will be having the continuation, whereas it is not true for the nodule. So the nodule will be localized to a certain area, and if the X-rays fall on it, then it will show up like this. If the X-ray reaches the film, it will appears black. If no X-rays is coming to the film, then it will appear as white. That is a basic thing with the X-ray and how they appear on the film. So that is the reason why you have to see the opacity and the size and also the tail if you want to differentiate the normal pulmonary vessel from the nodule. So now coming to the unstructured interstitial pattern. So the unstructured interstitial pattern, this can be seen because of the any leakage from the interstitial capillaries. So that leakage will give the fluid appearance, and you can see the diffuse haziness in the lung lobes. Okay. And apart from that, the low grade inflammation can also see the unstructured interstitial pattern. So this unstructured interstitial pattern, the peculiar radiographic change you will see is the increased opacity of the lung due to the attenuation of the X-rays. For example, if you see here, this is the lung lobe, and if only particular area is having the lesion, then only this lesion will be appear as haziness in the X-ray. But in case of unstructured interstitial pattern, so wide area of the lung is damaged. So if more areas of the damage is there in the lung, so obviously when the X-ray falls on this, for the convenience I am just writing the X-rays are traveling like this. So it will appear as the superimposition of the all small lesion areas. So that will be seen as the haziness distributing all over the lung. So this unstructured interstitial pattern is manifested in the form of increased opacity of the lung. So there are certain normal causes which can lead to this kind of changes, like the improper radiographic technique. If you don't use the proper KV or MA, then you can see these changes. Apart from that, if the animal is obese, you can expect some haziness in the lungs. And the common thing you can see with the geriatric animals is the unstructured interstitial pattern is diffused all over the lung lobes just because of the age related fibrotic changes in the interstitium. That is completely considered normal. This is about the most common things you should know about the lung patterns.